Assalamu alaikum rahmatullah. Good afternoon, ladies and gentlemen. The subject of the ground round today is very interesting and unique. And I think this is the first time to be presented in such a grand round. And it's also unique because an anterior segment consultant is moderating a retina consultant. Huh? آخر الزمان يا دكتور هدى. Why not? You moderated the retina before? بس هم دائما متكبرين علينا. هم الرتنا متكبرين علينا دايم. The subject today is making a grand round grand. Again, the speaker of today talk is Professor Marwan Abouammoh. He is consultant vitreoretinal surgeon and the director of the Retina Fellowship at King Saud University. Marwan.
Assalamu alaikum. Thank you, Dr. Hani. So I've been informed 6 to 8 weeks ago, just 6 to 8 weeks ago, for the first time, that I need to present a grand round, administer a quiz to the residents, supervise case presentations. There were 2 case presentations, but then they came down to 1. What any of us usually do is pull his latest publication, ask the secretary to plot it on a PowerPoint presentation, come to the grand round, read through the bullet points, and that's it. Others may pull an old grand round, nothing that makes him nothing. يعني, he can't do this anyway. Nothing is in it يعني, and there is nobody to tell him he cannot do that. Whether he updates it or not, he presents his grand round and leaves. And some other also would choose an interesting topic and do their best to deliver the grand round that is beneficial to the audience and attendees. So this is the outline of my lecture. So the idea was, when I opened PubMed, in order to look the latest publication within my area, I decided to write the keywords ophthalmology and grand round. Then I chose this topic as the lecture of the day. So this is the outline. And so we start with the history. How did grand rounds start? Around the late 19th century, in the late 1800s, there were many ways to teach medicine. Then came along Dr. William Osler. You know him from med school, Osler's Notes, where he was convinced that bedside teaching is the way to go, where trainees learn through bedside teaching, faculty, along with the trainees, moved from patient to patient, pointing out methodology, disease pathology, diagnosis, and treatment. He even published in JAMA back in 1901 a lengthy article titled "The Natural Method of Teaching the Subject of Medicine." Many parts of it still hold true till our day. So here you see on your left side Dr. Osler surrounded. This is a clinic surrounded by trainees and staff. It is said that there was 75 attendees at the time. So as the number increased, they decided to shift it to the auditorium. On your right side, you see Dr. Osler beside the patient. And behind him is the old style PowerPoint, which is the blackboard where you have the data and information of the patient. The case is usually presented. Then the patient is brought in, or he might be there from the beginning in the auditorium or the hall, and then questions are asked both to the presenter and sometimes to the patient. And this is how the traditional approach of grand round was created. Prior to the understanding the concept of aseptic technique, there was the surgical grand rounds and surgical specialties where they have the surgical amphitheater, which is not anymore, obsolete, as you know, for the fear of sepsis. On your right hand side is a grand round at Kekesh 20 years ago in the main building. Back in the main building, the title of this lecture was Acanthamoeba keratitis. So this is an anterior segment topic for you, Dr. Hani. And the grand round venue was small, and most of the time it was fully packed. But as Dr. Imad Aboud described it, very lively. It is not known who coined the term grand, but a normal practice then was that patients were present during the residents or trainees presentation or immediately after the presentation, as the patient was the theoretic focus of all clinical activity. Sandel in a publication described the grand round back in the mid 20th century as free discussion between thinking men of widely different interests and experience that instilled character and inspired future physicians. After that, yeah, he described the past. Yeah, the same. Yeah. So then the era of graying of the grand rounds appeared at this time, which is the mid to late 20th century, which was just around the corner. Disease pathology became the most integral discussion topic. So the presentations were now monotonous, lecture-based, bullet points, whether on before PowerPoint there was overhead projector or the carousel. And but it did get rid of the short appearance of patients in the auditorium. Some even questioned questioned it ethically, bringing a patient in hospital gown in front of an auditorium which was full of people. And plus, it was the mid or late 20th century. The presenting patients were only usually those of rare and uncharacteristic findings that were not affecting most of the patients with the same pathology. So they stopped doing this. Then, in the late 20th century and the first decade of this century, the grand rounds became a forum for translational seminars, combining clinical advances, research, top-of-the-notch randomized clinical trials like never before. Still, it was didactic, PowerPoint, slides, and it incorporated even less and less cases. So now we know about the history of how grand rounds evolved. So what are the objectives of the grand round? So the number one reason is to support the postgraduate education. The grand round is usually it's not a standalone thing. It is usually accompanied by case presentations, fluorescein conferences, imaging conferences, didactic lectures, morbidity, mortality meetings, subspecialty lectures. It is also a place to expose the trainees to the best of medicine and science, exploring a problem in a comprehensive manner, questioning methods, statistics, pathology, understanding biochemistry behind the disease, immunology. It is also one of the few other venues where you have many specialties, many subspecialties, or even people from different departments to assemble, meet, and discuss problems of mutual interest. You can socialize, meet the young and old, the iconic, the average, learn how to articulate presentations, learn how to disagree without being disagreeable, make announcements. We need to make sure to engage other parts in the clinical team, whether nursing, pharmacy personnel, health technicians. We work in an interprofessional team, and we need to share this great experience with our teammates. And also, you can do business. Quick word with a colleague. Talk to the head of the department or lobby him. Talk to a resident about his 6-month delay in writing the case report. A visiting professor might present or even be one of the audience in order he gets an impression about the depth or cohesiveness of the department at rounds. Well, الدكتورة سوسن. Oh yeah, correct my pronunciation. Hors d'oeuvre. So snacks, which means snacks, appetizers. Sometimes some people consider it his main meal of the day. Some people come for the snacks, not for the grand round, and they attend the grand round. They did a study about whether or not having snacks makes a difference, and whether or not, if you have snacks, these snacks were free or not. And they found that having free snacks made people care to attend the grand rounds. It is also a place to show the program showcase the program to residency applicants in order to plot their or rank their preference list. So now that we know the objectives of grand rounds, why is there a declining interest or poor attendance in grand rounds? It's not something specific to ophthalmology, and it is a general problem. And the proof is many have studied this issue. And the first reason, according to these studies, is poor organization. Like not putting a timetable in a correct way. Scheduling should be early in advance. Avoid cancellation in the last minute. Avoid editing in the last minute. And because of the evolution of the grand rounds that you have seen now, the grand rounds or the lectures became more monotonous. There is no back and forth. There is no interaction. And this have affected even some people who have good teaching skills, but they cannot present these teaching skills in grand rounds because they're just trying to finish the slides and read through the slides. Another thing is, as most of the attendees are residents, they're usually focused about disease. How can the patient present? How can we identify what's the actual problem with him? But we now, many times in grand rounds, lack the patient-centered focus that the residents need to learn and understand. Having busy schedules and commitments that interfere with the grand round I think is not of an importance to us, because I believe most of the ophthalmology departments have this time as a protected time during the week for the grand rounds. The more the subject is specialized and focused, the more detached some faculty feel towards the grand round. And thus, some have thought of having some courtesy slides for other subspecialists in order to relate and understand. There was a time where the first row was full of department leaders, heads, seniors, each waiting for the presenter to finish in order to argue with him about the latest published research that has been published a few hours ago, which made it more exciting. Interruption by pagers, listening to WhatsApp voice messages, is a sign of disrespect and negligence and makes even not the audience not wanting or not caring to come. Also, the presenter would be hesitant to present any grand round lecture. Nowadays, most institutes have an excellent venues in terms of location or having a good amount of seating and parking, given the proper organization. So, what about the case of ophthalmology? This is in general, grand rounds in general. But what about our grand rounds, ophthalmology grand rounds? Since the start of KKish, there were grand rounds, weekly grand rounds. But the first recorded grand round was back in 1986, and you can find it in the library. The title of the grand round, as usual, retinal. And the title was Retinal Aneurysms. The moderator was Dr. Khalid Tabara, and the presenter was Dr. John Cavender. Asking both of them, you would know that both came in order to establish the first residency program in the country. Note that the title has in between brackets the word medical grand rounds. We'll come to that later. The date was the 7th of July, so it was during summer time. Apparently, there was no recess, and the format was a lecture, then a grand round, then a case presentation, all presented by the attending. This has later changed. Case presentations were out, and the quiz was introduced. Of course, every now and then there are fluorescein conferences, which has changed now to imaging conferences. Not sure when exactly the quiz were presented, but then the case presentations were reintroduced in 2004. I was the second resident to present the case presentation. The case presentation was considered a continuation of the grand round. The first 2-3 rows was full of seniors, and you finish your grand round. The grand round would finish. You present your case as a resident, and all of the seniors will bombard you with questions. And good luck surviving that. The day and time. So it has been always in the afternoon, midweek, whether Monday before, and now it is Tuesday. Then it has shifted to end of the week. Back then it was a Wednesday, then back to midweek. The grand rounds at some times had visiting professors giving lectures, and it has always been well organized, and the venue was always good enough. Snacks are always there. Snacks is the most important part of the grand round, as you know. And then in 2015, there was a split. This split was there is no more joint residency program. Now we have more programs in 2015. And the reason was that we should accommodate more residents. With having more residents, then you have more attendance because residents number has increased. But what about the staff from other programs? Are they, since you have engaged them in the residency program, and each hospital has its own residency program, are the staff involved in the grand rounds? Are they attending? Are they coming? I leave this question for you to answer. So then in 2003 came another split. You know, when you split a DNA and you can have SNVs, single nucleotide variants, this single nucleotide variants can be insignificant or can be a nonsense or a missense, can be significant and mix up the whole DNA. However, there was another split. One of the hospitals decided to carry its own grand rounds. One of the reasons, and which is obvious to all, is the commute time, whether by car or by public transport. It's still a long way from their hospital to Kaikish. We should appreciate Kaikish for holding grand rounds non-stop. It is not cheap, and probably Dr. Huda knows that. It is costly. And it is impossible to ignore or not to acknowledge and be indebted to the efforts by other contributors like King Saud University and others. So, as we understand now, the main reason was the commute time. But I think this applies to all. We all have a problem with the commute. This is the commute time, whether by car or by public transport from the mid or the city center, where most of the hospitals are situated or are in this region of the city. So, is there something else to happen? Unity is strength. And Helen Keller, وتعاون على البر والتقوى ولا تعاون على الإثم والعدوان. Helen Keller also said, alone we can do so little, together we can do so much. Muller, while talking about towards the end of the 20th century grand rounds, said that the transition of grand rounds over time from an interactive teaching activity involving living patients to a passively received didactic lecture, like I'm doing now, has led some to suggest that the term medical grand rounds, you remember the slide by Dr. Tabara and Cavender, is no longer appropriate. I'm not sure if this applies to ophthalmology, but again, nothing grand about something many try to escape or avoid. Okay, this is ophthalmology. What about other programs? So I ran a survey. Tried not to involve ophthalmology, but apparently some have, few have answered. I ran the survey, less than 100 participants, and asked them many questions. And of these questions is, during what time of the day is your grand round? The majority stated that it's in the morning. And the second question was, on which day of the week do you have your grand round? And the majority was midweek, like us. The second most common day is Monday. It seems that they have a separation anxiety and they decided to keep it on a Monday. And the third question is, who usually presents the grand round? And I was surprised by the result, which is usually the resident, supervised by an attending. An attending may present the grand round, rarely a fellow, because fellow, have their own activities, they have their own CTRs, their own journal clubs. They're busy doing other stuff, or busy in clinic and OR. So now, knowing what's going on in other programs besides ophthalmology, how can we increase the effectiveness of grand rounds? This has also been studied and was part of faculty development in many universities. One of the best was the one done by Washington University in School of Medicine, in which they stated that to increase the effectiveness of grand rounds, you need to first perform a constituent-wide needs assessment, identify the educational needs, develop a curriculum. You should not leave the selection entirely to presenters who may choose topics that are convenient but are not of great interest or value to the audience. And regarding the subjects, in addition to subspecialty topics, should include diverse subjects such as patient safety, insurance, health economics, education, artificial intelligence, and so on, for a change. And we should not forget the team, the non-physicians in attendance. And we should also provide training to the residents in leading case-based discussions. We have seen that the majority of other programs is the grand rounds presented by the residents. And you can ask about grand rounds done in North America. Grand rounds are presented by the residents, usually, most of the time. We should have a grand round that has a mix of interactive and didactic education to stimulate the learners. And we should not run over time. In fact, stop early, leave time for discussion and at the end and questions. As for the evaluation, currently the evaluation is just to make sure that you have collected the CME hours. So probably not serving its intended purpose. And because we did not see a change in the last 15 years, maybe, in the grand rounds. And the grand rounds wax and wane according to the presentation and the presenter. The leaders are of utmost importance. They can promote discussion, involve audience, insists on regular and punctual attendance. They should take an active leadership role, discourage scheduling other commitments and meetings during the time of the grand rounds. The grand rounds, when led by a dynamic head, championed by an institute leader, and supported by division heads and division members, is a triumph to any specialty. That being said, I conclude that the grand rounds aims, objectives, and expectations, now you know that it has changed over time. The new strategies to refresh the grand rounds should be suggested and adopted in order to regain interest and boost attendance. And the leaders and heads should take an active leadership role in restoring grand rounds to its former glory. Thank you. You know what is this? This is called the Diwan in Al-Hijr. So the Nabataeans used to sit here, and the speaker of the grand round used to stand here on these steps. This was hundreds or thousands of years ago, 3,000 years ago. Not so long ago, 20 years ago, my cousins and me came here to do snacks and bring the ni'ami with us to make kabsa. Thank you.
Thank you very much. It's a very nice review for me, but I would like if you could add a suggestion. How could we increase the grand round attendance? I mean, now we are facing some difficulties for our staff to attend. Sometimes they didn't have any commitment, they didn't have any clinical or surgical duties. They are kept free, but in spite of that, attendance is far below our expectation. For those who are not within the premises of KKH during their working hours, we suggested to the medical education to have a link where it will be broadcast and everybody could attend, and we could see the attendance and the system. And I think Hudashi could answer this point. But how could we increase our staff attendance as an external speaker, not from KKH? Because from KKH, they will not like your comments, maybe.
So Kekesh is a big hospital, and other ophthalmology venues are small departments. In a big hospital is, as you said, it is difficult to control people or follow run around behind everyone, making sure he attends. But in a small department, it's easy to see who's there and who is not. Maybe you will feel have a sense of guilt if you missed in a grand round, because it's just you just go next door and there is the grand round, you can attend. And if you're not there, everybody will miss you. Where is Dr. Misfir? So I think it's easier in a small department than a big hospital. I work in a small department. I cannot have specific points regarding. Maybe on the side I can talk to you, and so they won't. There was the COVID era. The COVID era presented to us the webinars and the online grand rounds, and this has carried a little bit carried on a little bit after the COVID was gone, but for some reason it has stopped. But it was a good option rather than trying to come on time through this commute from my place to this place and with a traffic jam. It is easy that stay in my place, carry on my usual work, and then when it's 2 o'clock, I open the webinar or the online site and listen and see the grand round.
I might suggest something for you, Dr. Misfir, but KKH staff might angry from me. You can trace the attendance of the grand round for 1 year and calculate it. The one who is not attending the grand rounds, give him duties, give him clinic, give him OR. Okay, use his time because he's not interested in the academic part, this part. So give him duties at this time.
Plus, not attending is sending the wrong message to the trainees. So, yeah, fellows and residents.
If I may comment, you spoke about the era of the COVID, the time of the COVID, and despite the COVID, people managed to get in touch, and not only in Turkish but all over the world. So why insist on the physical presence of someone if you can, for example, if you can through the technologies gather more attendance? You don't need a parking area, and you don't need the people outside KKH to come through all this hectic traffic, and yet have the same conversation. I wonder really, because the online meeting, the online grand rounds and all the activities, especially that it's not really around. You know, when you hear about someone doing around, you expect someone examining a patient. So I don't know what is the meaning of calling this a grand round. It's not round. I think you should have also stressed on the fact that it's not only grand, but also round, because it's not around. These are a collection of lectures. So regarding Dr. Hani's point is to, tag someone with a GPS and see whether he or she in at KKH or not. I don't think that this is the right suggestion, because, after all, if sometimes the title of the lecture is absolutely not of any interest to me. So why should I be forced to come and attend? Probably there should be a minimum number of grand round activities or activities that the members should attend. But definitely some activities, why should I come and just upload and eat? I think
I
this
would
is
come
what,
to it. I will come. But
yeah,
but the
you
thing
know,
but the thing you want
and especially
the
if there is no food, why
the
should I
rounds.
come?
No food is a problem, as the study showed.
Yes,
But
if the subject is not of interest to me,
the
if there is no
rounds,
food,
there
and if
has
there is
been a
no
change.
parking slot,
There has been a change in in grand rounds. The rounds are meant to teach in an interactive way the trainees in medicine or in any other specialties. We have taken whatever is there, and uh, one of the attendings told me that there was a time where in Kaikish, where we brought the patient to the grand round.
you know, but things change. You know,
So,
now
so it should we should I mean
things
we
change.
should make it interactive. I mean,
no,
like few weeks ago.
excuse me, Marwan.
Uh.
It's not like that. Things have changed. You know what? Now you can talk with someone in another continent. Okay, in the past, the people have to be in the room, and probably if the microphone is not okay, they have to be in the first row. But this have changed. Why insist on something? Now you can show you can display whatever you can share your slides, you can do
the magic word is interaction.
You can still interact.
I can attend, switch on my mobile phone, put it in my pocket, I say I attended, but there is no interaction. We need the interaction. The grand rounds format has to respect this, to be interactive a little bit more.
Professor Marwan, thank you. Thank you, Professor Marwan, for giving this interesting topic for discussion. I noticed more attendance when we have a visiting professor. And I would like to ask you, you show a slide where residents in other subspecialty, non-ophthalmology, I believe, giving the grand round. So how is the attendance?
How is the attendance
when the resident is...
I didn't ask this question. Yeah. I can run it and see what's the results. But the thing is, what was striking that most of the programs in the country, I'm talking, that the resident is the one who prepares the grand round, supervised by attending. Those who were in Canada, those who were in the US know that the resident present the grand rounds. When you have a resident presenting the grand round, he's more nearer to the residents and the trainees. First of all, he can address them maybe better than senior attendings. This is one. And second thing is it's a practice for him. I mean, you're a senior. You go present in conferences and international seminars and national conferences. But when is the time that a resident can practice this? Let him faint here. It's okay. But this is the place that let him faint here and not abroad when he goes present nationally or internationally. Dr. Ahmed.
Thank you very much, Prof. Marwan. It was a very interesting and important topic. I quickly have two comments. One comment is regarding the attendance. The attendance is usually people would be very keen to attend because of the topic if it is attractive and because of collecting CME hours. This is one thing. The other thing is people are also very keen to attend. Actually, Kikish has enabled a very good tool enabling the channel where they post the lectures and then anyone can follow up and see. In my original university, UBC University, there is still broadcasting each grand round till now. The other comment actually is as regards how do we encourage people to attend. So you have provided one solution in one of your slides regarding putting this as a curriculum, not allowing everyone to choose the topic by his own. But this will put us in a situation that you are not enabling a room for innovation, because if it is a curriculum and you a priori identify the topics and tell people here are the topics, you go and lecture on these topics, then this is good, but it becomes another curriculum that you are educating. However, you need to compromise between enabling a room for people to select topics that maybe they are quite aware of something that happened, something they want to convey a message through it. Thank you.
Yes. Except for the curriculum, there was a time where you pass by medical education, ask them about the lecture and the presenter after 3 months, and they will give it to you. Before, not now. So having a curriculum will help you schedule your commitments better. If you want to miss one grand round, it will not be this grand round. No, this is interesting. I will attend, or you will work your other appointments in order to attend. So having a curriculum is helpful, actually.
Dr. Abouammoh, if there is a curriculum, the first lecture that we will miss will be your lecture now.
This lecture falls under medical education.
No, if there is a curriculum, this is the first that will not be on the curriculum, because no one will think of this. That's why, if you give it to someone,
the curriculum. What I mean with the curriculum is having a set timetable. There is something to present. You know what is being presented.
I know, but if you're given a subject, you will not have thought of this.
Not a subject. My subject is retina, but I chose after I.
So curriculum meaning what?
After I spoke to Dr. Huda that it can fall under medical education.
We used to do that with subspecialty, and we used to do that with the grand round. With the grand round, we used to know the original plan was to have physical presentation of patient, and all the grand round subjects already distributed by the division chair to the medical education. For this reason, we know that there's a presentation in October 2025 by Professor Hani on that day. And we know the title. And if the title is not approved by the medical education, they will ask the lecturer to change the subject because it's already presented by somebody. What I would like to say that on spite of the subspecialty, regardless of the grand round name is the same grand round or anything, but it's an academic activity. Few months there was a grand round of the subspecialty. Only 2 of the division members attending the grand round here, and all of them KKH staff, only the resident and the fellow. Only 2 of the consultant of the division. And on spite the specialty. It's their specialty. It's not that it's not my interest. The ophthalmology is one field. I would like to attend the coloplasty, I like to attend the retina, I like to attend the intersegment. I have to be up to date on all the specialty, even if I'm not practicing the same subspecialty. I don't know if you agree with me or not, but this is what I feel it's right. What is Professor Hani suggests that to those who are not interested in academic activity, they should have other duties. This been discussed with the higher administration and been suggested. We have the record of all the attendance for all the physicians in the last, I could say, 10 years. For this reason, we could look at it. We could send an email to those physicians who are not interested to attend the grand round. We could then compensate them with an academic, with clinical or surgical activity if they're not interested to attend the grand round. So I think the suggestion of Professor Hani is great. Thank you.
Dr.
Those one who are not at KKH, I think Huda should create a system where there is a link for them to attend. I don't know if this, we used to have it. Are we still doing it or not?
Dr. Hamid?
Yeah.
I'm not asking Professor Hani to come from university driving for 1 hour to attend a 1 hour presentation. He could sit in his office, he could open the screen, he could listen, he could interact with us. But KKH staff, I think it is one of their duties to attend the grand round.
We can rotate the grand round. So sometimes it's here, sometimes it's there. So we can attend from our phones too.
This is also a system that is done in some specialties in Riyadh.
Yeah. So.
But you have the problem with commute.
No, we do the online too. So if you do it.
Dr. Abdurrahman.
Do a mixture rather than doing it online, just for classes. So a lecture hall in the university, for example, that's what classes are. So the solution of the split that happens, if every hospital that has participated in the residency program, they can assign a lecture hall and just broadcast it.
So there are many solutions. You need the
One suggestion, I think it's when we that there is I prefer that the ground round presentation subject and material should be reviewed by a committee. Should not be just random and left it to the presenter.
I mentioned that, yeah.
Second, I prefer to have some financial compensation for the one who will do the grand round. If we make these things, it will be very, professional. That you'll work, prepare your presentation. It takes maybe hours from you and days to collect all the material. If there's a financial compensation for you, you'll feel more happy and you feel that your efforts been appreciated.
There you go. There are many ways to fix a Dr. Sousan.
Pride in being at Grand Rounds when I was here like over 30 years ago. So there was no such thing as, Grand Rounds is going on and I'm not going to attend. It was like as soon as the time came, we had to be at Grand Rounds. A lot of us attended also the subspecialty lectures, which were organized ahead of time. And yes, I remember distinctly, as Dr. Misfer said, that we used to have the schedule of the Grand Rounds posted on the wall of where we used to have grand rounds, for the entire months. You asked earlier, I don't know where the quiz was taking place. Well, the quizzes were given exactly just after the grand rounds.
When did they start? At what year?
Soon after. As soon as the residency program started, actually, very soon afterwards. But it wasn't announced like we do now, like quiz. It was part of the grand rounds. You sit for the subspecialty, you sit for the grand rounds lecture, you hear the quiz. Everybody hears the quiz, including the attendings. Okay, and then immediately afterwards, there are the answers to the quiz. And then people go out, they have a snack, and they go in the next rooms where there are patients to be seen and examined, for the case discussions. And this is why it was called rounds, because actually you are rounding around patients. Now that we have CTRs and a lot of people, have their specialties, have their own case presentations, we don't really need to bring presentations. We can definitely bring in case presentations as case reports here, which is a good time for the residents to practice their communication skills. But I really think that grand rounds should be given by a senior person, because then the delivery is much better. The person has had the time to experience and do at least 4 case presentations during the residency year, at least 1 case presentation per year. And the nicest thing, which is what you alluded to, Dr. Marwan, is that it's very important to have time for discussion. The nicest parts that we remember about Grand Rounds were not the titles of the lectures. We remember our seniors fighting against each other, discussing things, back and forth, and that was the learning experience. So if we can bring this back to the point where, it is, the subjects are carefully chosen, as everybody mentioned. They are well listed in advance. No last minute cancellations, because I know that's a super big headache for the grand rounds, for the medical education department, and that there is a possibility to see the people who are attending online. We have technology, so we should use it, but actually see the people who attend online and have back and forth questions and answers with them and discussions of this topic. This is the educational experience, in my opinion. Yeah, so that's what I have to say.
Thank you, Dr. Sousan.
You're welcome. Thank you very much for everything. I'm sorry, I don't have a question for you, but I was just giving suggestions.
You have said.
If I may ask, is the staff in the university, they have a free time to attend the grand rounds?
It's protected.
Protected time.
I think all of them, at least all, or almost all ophthalmology departments in Riyadh. No, not all ophthalmology departments have protected time, but most have protected time for attending.
But the university is protected.
Yes.
So how many?
Where are they? Huh?
Yes, exactly.
Me, I'm here.
So
those who have a residency.
But now we have a presenter from the university, and we have maybe 3 or 4 from the staff of the university coming to attend. I think all of them should have an extra session on Tuesday afternoon.
Commute time.
So take the grand round in the university, and we'll take the same excuse.
I have a comment regarding the current grand round theme. So at my time in my residency, it used to be you start with case presentations, then grand round, then quiz, then subspecialty lecture. That was the organization of the. Then the subspecialty lecture came first because the presenter does not want to stay late, and I understand this. So my suggestion is, in order to improve the exposure of residents to proper case presentations, I have been here. I was the only one who was here when I was the supervisor, and I understand nobody wants to stay late for case presentations. I suggest that the case presentations are presented immediately after the grand round. Nobody leaves the room. The resident starts presenting the cases.
It used to be like that.
Yeah, but before the quiz, now the grand round presenter or the moderator says, okay, now the case presentations, and the residents present the cases, and everybody is attending, not only the supervisor. This will improve the overall
Dr.
experience.
Suleiman, thank you for your suggestion. I believe they started from today. Now we have the case presentation and the quiz. This is came from residency and fellowship.
So
After as you suggested.
Yeah, it is always there, but it is not. Everybody leaves, then the resident comes and.
This what will happen today.
Yes, I know.
Yeah.
We want it to change.
Dr. Marwan?
Yeah.
Yeah.
Dr. Osama, yes.
Assalamu alaikum. I would like really to start by thanking you. You brought a very important really a message to every one of us that this is the time to change the strategy. This is the time to change the style of the grand round. I've been talking years ago to some of the people in charge of it, and even I've spoken to Dr. Shahwan. I wanted just to translate my experience when I was in Johns Hopkins a few years ago, whereby I attended their grand round, and it was more or less similar to the model that you're suggesting. So you're suggesting to let the resident presenting instead of the senior resident to present instead of the consultants, and to present the an important cases with an assigned a professor or whoever from the faculty. I believe innovation starts always from these rare and uncommon cases, and that was a very nice theme. Every week they choose a subspecialty and assign one faculty. He supervised the resident. They don't put a lot of information. The senior residents interaction with the faculty was direct, and they felt more confident. And honestly speaking, a lot of the cases that they presented there, it was published also because of the a lot of people opinion in adding it. Needless to mention also, it was really a positive atmosphere to everyone. For me, I was attending glaucoma, and I was very comfortable sitting there and even learning from the way how they were interpreting rare cases, in the front. So I think we can start that one as as a trial period, or you may not impose it to every grand round. Maybe you can do it once every 3 months and see if people are accepting it or not, and then try to see the response. You can do a survey at the end of each of these lectures and see it. For me, I feel this is one of the best experience I've ever seen, because just doing the spoon speaking is not gonna help us. That's the reason why people are moving away from the traditional grand round. In the past, I remember I was a resident, and all what you have described and Dr. Sausan was telling you, I went through it, and there were a couple of patients that we brought in the next room and we were able to examine. But remember, at that time our number was less. We can still do that by a video recording of the patients, or whoever, any one of our colleagues in any other hospitals, they can video record and, as you mentioned, broadcasting it, and there is nothing against it. But it's the content. Now is I can log in and I found a lot of lectures that I can learn from it whatever time more convenient. And I agree with you that broadcasting is going to help us. Rotating also is one of the things that you would suggested, but that's really a very courageous really topic to present, and I congratulate you on choosing it.
Thank you. Dr. Asausen again.
Yeah, sorry. Yeah, I just want to touch upon the subject of rotating what goes first in grand rounds during those 4 hours, because I was director of medical education from 2005 until 2012, and then again in 2018 and 17. But we've experienced everything. The first one is the one that you mentioned, where we start with subspecialty lecture, then the grand rounds, then the quiz, then the case presentations, and that worked for a while. But then by the beginnings of the year 2000s, something changed and the attendance started to go down. So what we did to increase the attendance of the residents, the problem was the residents were not attending the subspecialty lecture on time. Yeah, this is what we were seeing. And so what we did is to kind of force people to attend on time. I put the quiz at the very beginning. Just the quiz, not the answers. Just the quiz, so that I know that all the residents are here punctually because they need the quiz for their marks. But we kept the answers for after the lecture, so everybody can, including all the attendings, can actually hear what was asked and what were the answers. And what we did was quiz first, case presentations, for whoever wanted to come in for the case presentations from the attendings. Now they have the time. They no longer have to rush in at 1:00. They can come in at 1:20. It's doable, And followed by the grand rounds at the usual time, 2 to 3, followed by what? By subspecialty lecture. This was carried on for a very long time. But then, subhanAllah, by 2011, people started complaining that the residents were too tired at the end of the day from taking notes for the subspecialty lecture, and that their attention span was no longer good, and that that needs to be moved back up. The reason the program worked very well in the beginning, when I established it like this, is the residents were there on time for the quiz. The case presentations were presented at a time where it was possible for people who finished their OR and their clinics to come in, because it was not 1:00 sharp. The grand rounds, everybody attended, and everybody had the chance to see the results of the quiz, because it's also a learning opportunity for the seniors and not just the residents. And then for the residents, they could stay longer. After all, they just graduated from college, and I know that in college, you stay longer to take notes and you attend lectures. That's never a problem. And when you go into an international meetings, sometimes the meetings finish at 5:00 and you're attentive. But this was just a suggestion. It worked very well in the beginning, but by the year 2011, it started to go down. I don't know. So there will be hypes and and troughs, but you have to take that into consideration when you want to change the sequence of things. Yeah, all pros and cons.
Thank you.
Thank you.